Nothing contained in this podcast should be considered a substitute for professional medical advice. This content does not represent our respective employers and is purely the opinion of the podcast hosts. We are not your personal medical providers. Sorry, friends. So, if you have any questions or concerns or are seeking advice, diagnosis, and or treatment, please seek individual, personalized advice from a healthcare provider in your area. We are not liable for any risks or issues associated with using or acting upon the information contained in this podcast. This is intended for educational and entertainment purposes only, so enjoy the ride. Welcome to Medical Media Mixer, the perfect cocktail. I'm Nicole Peniston, clinical psychologist.
And I'm Tara Prisco, physician assistant. All right, so where are we in timeline of world? We are the day TikTok died.
We are RIP.
Well, it might be back by the time the episode airs, who knows?
Or something else will be back.
Something similar. So I never did like TikTok personally. I just literally made account for the podcast. So I wasn't married to it, so I'm good.
Yeah, if you looked on mine, I had like 2 personal posts and then everything else was for the podcast because I didn't know how to do half of the cool stuff that I saw people do, so I just didn't try.
Yeah, I'm still learning the whole how to post and edit and make fancy things.
Well, maybe now you don't need to learn.
Yeah, exactly. We'll just stick with Instagram and YouTube for the moment.
Yes.
All right. So I have one day when we have like enough listeners to do like a live show. I have a venue.
Ooh.
So I just dropped my kids off at my niece's birthday party, Asbury Lanes.
Ooh.
So it is an old bowling alley with only like 5 lanes left, but it's a event space with like a stage, 2 bars, like a dance floor type thing, or you could put like seating in there. And it's like a really cool vibe.
Very
like,
cool.
Yeah,
Maybe we'll just do it anyway and just our friends will show up and listen to us.
Yeah, but I figure if you're going to rent it out for a private venue, you have to sell enough tickets to cover the costs. But it was a really cool venue. And I was like, this is neat. All right, I see our future. And it's sort of centralized. And I figure most of our fans will start from our home state of New Jersey. So
yeah, hopefully. Also, how's the weather by you? Speaking of our
home state? Is it snowing? Let's see. It was a minute ago. It is not snowing any longer. Is it snowing by you?
It's been flurries for the last like 4 hours, but literally nothing is sticking. So I'm keeping my fingers crossed because they're predicting 5 to 8 inches.
Right, because you're further south and west, whereas I'm near the coast and we like have a line of like sometimes we get it and sometimes we don't. But my street is very randomly and strange that when we do get snow, it never melts because it must not get sun in the winter. The street is always a mess.
Well, and you're slightly like on a hill, so you're not like close to like
correct
the ground and the heat from the Earth's core or whatever. I don't know.
Yes, the Earth's core is totally.
I'm not a doctor of meteorology or earth sciences, okay?
All right, you're not a geologist or
there's many things.
A volcanologist.
Definitely not a volcanologist. That'd be cool.
It would be, yeah. But all right, so we got some interesting topics. I'm ready to hopefully not gross you out, but kind of.
You're going to gross me out either way, but speaking of grossing out, I'm going to mute myself if I need to cough because I'm still apparently have bronchitis.
So. Fun.
I will not cough into the mic for all of our listeners to hear.
Yeah, because I don't have to edit them out. That'll be fun.
No, just leave them in.
All right. So my drink, and I'm going to put it on the screen because it is kind of cool. It is called Bug Punch. It has gummy worms in it, and it is bright green.
Nice.
So what's funny is actually the drink itself is like a standard, typical drink. And the gummy worm idea came from like a kid's, Halloween themed idea.
Yeah.
So the kids' version was called Bug Punch Mocktail, but what I made was a Midori Sour Bug Punch. So it has 2 ounces of Midori, half an ounce of lime juice, half an ounce of lemon juice, basically poured into the glass over the gummy worms with some ice, and then top it with 2 ounces of soda water. And it's nice and light. Midori is pretty light. I never really had a Midori Sour before, so far so good.
Yeah, I think I've only ever had Midori like mixed into other things. So.
Yeah, so it's pretty neat. So what topic might we have with Bug Punch?
Something about bugs, I'm afraid.
Okay, so the movie is called Bug. And I forgot to write down what year it was, but it was in the 2000s. It's Ashley Judd, and I love Ashley Judd, but this movie wasn't good at all.
I was going to say, spoiler alert to our listeners, I too watched this film and I could not get through it. And then I put it on the background while I was working, and it's a trip.
It is. It is.
Also, Harry Connick Jr. is in it, which you did not
He
tell me.
is. Yes. Harry Connick Jr.'s in it. He's not as much, but he's definitely in there.
I wonder how they got sold that film, like what their agent said to them to make them go for it, because it is a wild ride.
I don't know. Maybe they just needed a payday. Maybe it was just like,
I feel like it was at a time in their careers where they could be a little bit more choosy, but who knows? Who am I?
I don't know.
Maybe
I don't know.
They really cared about the depth of the story.
I mean, and sometimes the actors and actresses are like doing their thing, and then somebody somewhere in editing and directing makes it like worse. Hence Cats. I know. Hence this movie really was bad.
True, but like some of the dialogue, some of the things, they knew what they were getting into.
Yeah, I don't know. All right. There will be spoilers if anyone wants to watch this movie, so sorry.
Spoiler alert.
So basically the premise is this waitress played by Ashley Judd, Agnes, works at this summary calls it a lesbian bar. Okay. I don't know if that terminology is quite perfect, but okay.
I mean, it could be called something worse. I feel like that's
I guess so. She lives in a rundown motel in rural Oklahoma, the middle of nowhere. They allude to the disappearance of her son about 10 years before. She seems to have a hard life. She binges on drugs and alcohol with her friend RC. Agnes gets a bunch of different telephone calls that she believes are being made by her abusive ex-husband who recently got out of jail. Supposedly, I didn't really get this whole backstory, but according to this summary, he had attempted to murder her and stalked her. And then she put a restraining order against him. So one night, Agnes is out with her friend RC and working at the bar, and they introduce her to this guy, Peter, who seems a little socially awkward, but courteous. He's a drifter, apparently. And they all go back to Ashley Judd's hotel room / apartment.
Agnes's hotel room.
What'd you say?
Agnes's hotel room. Same character.
I know. And they bond over sort of their mutual loneliness. He hangs out. They have awkward conversation. And their sleep is then interrupted by a malfunctioning smoke alarm. And Peter destroys it. And it's sort of something there alludes to he's upset by the fact that there's a smoke alarm in there in general. So that gives you a little clue into his mindset. The next morning, the ex-husband barges in while Peter's out and getting food. Ensues fighting with Agnes, and basically Peter comes back and Jerry leaves, the ex-husband. Then I don't know how many nights have passed, but Peter wakes Agnes up in the middle of the night and states that he found an aphid in the bed. Now, aphids, the only thing I know about them is they destroyed some flowers of mine. That's about all I know about aphids. But I know aphids and people usually are not an issue. But he seems very paranoid. He states that he's killing many aphids and that he's being pursued by some unknown people.
So I have a question, because I do remember that scene and I was very confused. Because I was starting to think that an aphid wasn't real the way he was talking about it. But apparently it's not like a beetle, but some other...
Yeah, it's like a little bug. They infest some plants and kill them, like make holes in the leaves and stuff. That's all I know is I had these really pretty plants by my pool they killed. But they don't affect people generally. So basically, he says that he can't tell her who's hunting him because it'll put her in danger. She feels abandoned, bursts into tears, and at first he storms out, and then eventually I guess he comes back. He states that he's a veteran of the Gulf War and that he was subjected to biologic testing by the U.S. government. And he feels that the anonymous calls were made by the government agents in trying to find him, or really in prediction or anticipation of him showing up, because this happened before he was even there. And he states that the room has become infested with bugs planted by the government as part of the experiments. He starts to become very erratic. He fights these bugs that apparently, Agnes can't see. But then over time, Agnes starts to share in his behavior. Her friend
before you get into that, I have one question. I don't know if this is going to be part of what you talked about later, but was this something that actually happened? Because we do know there was government experiments on people in the past. Is this coinciding with that time range, or this is after, or unknown?
I'm not sure. I mean, there is a character who comes in later who is from the government, but you'll see the angle they come at is different.
Okay.
So, her friend RC kind of is like, what's going on with you? Why do you think this? They're reporting things to the motel owner and they're saying no one else has got bugs. Peter starts getting more angry. RC, her friend, tries to convince her to leave Peter. And they mention that someone named Dr. Sweet is looking for him and had asked about him. So after Peter has an episode, Agnes fights with her friend RC, tells her to leave. Peter and Agnes basically close the room, covering it in flypaper, aluminum foil to fend off communications. Is basically like bug zappers everywhere. Peter believes the microscopic bug eggs were implanted in one of his teeth. So there's a lovely scene where he pulls his own tooth out with pliers. He starts using a microscope to examine this tooth and different things. He states he sees the bugs. He shows Agnes. She says she sees them too. He becomes very obsessed with the microscope. He thinks that they're living in his blood. Eventually, this Dr. Sweet does show up. So he is real, I think. There's questions at the end of what is real and what is not. But
when I watched it, I had questions from the very beginning about certain scenes, if it was real or not. But
right. And that's kind of how this ends too. Like, you don't know what's real and what's not. But essentially, Dr. Sweet comes with her ex-husband. So I'm not sure how they got in contact with one another. And they say that Peter escaped from a mental institution where he was undergoing treatment and that delusions about insects are a known symptom of his mental illness. But of course, they both mistrust Sweet. And this is a weird turn of events. This Dr. Sweet claims he can help her find her child that's missing, which, I don't know, some weird manipulation. I don't really get that. And then he sort of says, yes, the bugs are real, this doctor. So I'm confused because usually we're trying to bring people to reality. I'm not sure what's going on there. But he basically says that he can help them escape from the conspiracy. Peter comes out with a knife, sees Dr. Sweet. He argues with him. Dr. Sweet tries to get him with a syringe, I guess, to sedate him.
yeah,
but Peter starts.
Doctor just carries a
Yeah,
bottle
of course.
Thorazine in their back pocket just in case.
Absolutely. And then, we always sneak attack. That's how this works. So then basically Peter stabs Dr. Sweet to death brutally. And that
tracks. Yeah. It's the exact reaction that he should have had. Mm-hmm.
And then, Agnes is upset because she thinks, well, hey, he knew where my son was. And then Peter says he's not even human, that he's a robot sent by the government.
Stab robots?
And they bleed.
I mean,
right.
Is it blood or is it oil?
I don't know. It looked like blood, though.
Know.
It was pretty violent. It was a pretty violent scene. And then they just continue to sort of escalate this conspiracy. They convinced that Agnes's son was kidnapped by the government to lead her to Peter, that they were separately infected with bugs, meant to mate with each other. It really goes pretty far. And then they decide to douse each other in gasoline.
Mm-hmm.
And Jerry, the ex-husband, is furious about her unstable behavior. He tries to break into the room, but she injures him with a nail gun. Not sure where that came from.
You don't have a nail gun just sitting under your couch?
I don't know. We skipped over this summary. Skipped over the sex scene. I forgot. Yeah. I did mention that to you. The sex scene where they're somehow in the desert floating and things. It was very strange. But anyway,
that was one of many scenes I felt like was not real.
Right. Yes.
I mean, we know, and technically, but I didn't feel like they went out into the desert and then thought they were floating. I thought, they're just gone.
Yeah. So basically, they set themselves on fire. And the ending credits, they show toys in Agnes's room completely intact, presumably toys that she kept from her son. And the aluminum foil is not there. The room was last when we saw it covered in aluminum foil. And they go back to the opening shot of the film with the body of Dr. Sweet lying in the foil covered room, which is undamaged by fire. So we don't know which was real. So I don't know. The movie was crazy. But this was one of those things where I did sort of an opposite of my typical process where I'll see a show and then I'll make an episode about it. This, I knew the diagnosis that I wanted to speak about and I sought out a movie or show with it. So
I think I know what diagnosis you're talking about. But
Yeah, I
please,
mean,
tell me more. Tell me more.
yeah, this definitely, obviously is more in your end of the spectrum than mine, but it's something that I've seen in practice as a student and in urgent care and also as a primary. So delusions of parasitosis, which is exactly as it sounds. It's a delusion that you have parasites. And typically it's about skin. I've had people come in thinking they have intestinal parasites, but this is usually specifically something, bugs, mites, something in their skin. So often, they actually call this the saran wrap sign or the matchbox sign. I've seen it sort of as the Tupperware sign. People come in with little things, debris, something in a tissue, in a Ziploc bag, or in a little Tupperware as proof of what these bugs are that they believe they have. That right there clues me in. Typically these patients are cognitively intact, they're walking, talking, they're just very fixed in this delusion. And, they don't have any of the signs or symptoms of other things, which is what my main part is going to be talking about, is what things can really sort of infest or be on a person. There's really nothing there that seems to match that. Often they will have some skin lesions, usually from picking, because they start to pick and even sort of pull pieces out of their skin, which are actual pieces of skin, but they believe those are the insects. So they may have crusting and scabbing. It typically is in white, middle-aged, older women, but it can be in anybody. And it's very tricky. It's very tricky to get somebody convinced that this is not a physical issue and that it is a mental health issue. And which is, this goes to the movie though, which is interesting. I did not realize, and approximately 12% of people, the delusion is also held by a significant other. That
Folie à deux.
Yeah, I'm saying you know French, you can say it.
Folie
Yeah.
à deux or folie à famille.
And there's another one, folie partage.
Partage. Don't know that one. I know
shared
folie à
delusion.
famille is when several members of a family or a household share the delusion.
Right. So it's interesting. I didn't realize that part of it. So, basically our job is to rule in or out physical, actual, medical things going on, any other kind of rash, any other kind of infectious disease. If they're complaining of itching, you want to rule out liver disease, HIV, things like that, lymphoma, other things that can cause itching. You always want to rule out the actual other things before just saying like, this is totally a delusion. And I guess this is something you can I'm not sure if you know the difference, but delusions of parasitosis are supposed to be different than formication. Formication is the sensation of crawling, biting, stinging, but does not involve like that fixed delusion. I think we hear about formication more with like certain drug use.
So I think I could see how one could lead to the other.
Right. But they're saying it's considered separate.
So I would guess like formication, maybe a good example of that for the listeners would be how sometimes people may get restless legs as a side effect of medication.
Mm-hmm.
Because restless legs is like that feeling that something's going on with your legs and you can't keep them still. So I guess that's the only example I could think of to differentiate between the two, because you don't think something's in your legs. You just can't keep them straight because you have these unusual sensations, kind of like if your arm falls asleep and then it's waking up, those kind of pins and needles.
Right. Yeah. So it's like a symptom of something. It's not the whole thing.
I looked up folie partage. I don't know the difference. I think it's the same thing.
I think it's just another term. Yeah. And the French apparently have got this cornered. I'm not sure why.
Fun fact for you, French is used in a lot of government documents because it's more clear than any language.
I do remember that. There was like a treaty or something we learned about way back when we were in school, and it was written in French. I do remember that. Yep. So, my job in primary care, like I said, to rule out all the other things and then to hopefully convince them to get treated. Often it's a combination of primary care, dermatology, and psychiatry trying to help the patient get the right treatment. And there are some antipsychotics that are used for this. We won't go into details. So I want to talk a little bit about the actual things that can infect a person.
And this is where I get grossed out.
Yes, definitely. So step one is scabies, because that seems to be more along the lines of most of what these people would think, because scabies are very tiny. Mm-hmm. versus other things are very visible by the naked eye. So scabies is the one you really do have to rule out, because if I see a patient with scabies, I can't see the scabies with my eye. Scabies is an intensely pruritic, which means itchy, skin infestation caused by a specific mite called Sarcoptes scabii hominis. Hence, hominis, it infects humans, not other animals. And, it's pretty prevalent, 300 million cases worldwide each year. So typically what you're looking for are burrows. That would be, the sign that is essentially this is scabies. So little sort of tunneling, if you can kind of think about under the skin. I know the faces, we're going to use this for social media, all the faces you're making.
No, because they're not pretty faces. They're probably the same faces the listeners are making.
Yes. So they look like serpentiginous, like those kind of, if you could picture like a wormy looking tract under your skin. It's like a thread-like elevation. And, they're typically found web spaces between your fingers, elbows, underarms, belt line, warm places. So places, they typically go to the warmer parts of the body. Most likely, like I said, those places. There are other places that it can be. Geriatric patients tend to have it in their back because they're often laying in bed or, in a chair. So they're always on their back. So that would be a warm place.
Would that be something like maybe they already have an existing bed sore and then the scabies kind of get into that?
No, because they get through intact skin. We're not talking something that needs an opening. Often with a geriatric, you'll see like their entire back. And I've seen something like that in nursing homes. And it's a little tricky. Like, is this just another dermatitis because they're sweating or they're damp?
And I would imagine with the population, your skin gets thinner as you age. So maybe more susceptible to it.
Exactly. So skin things in the elderly are a little tricky. In children, it's more on their palms and soles. And like I said, it's a little tricky. There are some other forms that are a little bit more intense looking, nodular scabies or crusted scabies. I've not seen those before. So the diagnosis is basically a clinical diagnosis. Usually, though, if you find those burrows and it all makes sense and it's in the right places, you're going to likely treat for it. You're not going to usually wait because the treatment is pretty benign. You can send skin scrapings to a lab, which I did with a patient to try and bring them back. No, see, this really isn't, scabies. But you can, but in general, like I said, the treatment is just easy. And you can also biopsy a lesion and you may find scabies in that lesion under the microscope. But basically the treatment is typically something like permethrin, scabicidal agent. Basically you put it from the neck down, you let it dry, you leave it on overnight while you're sleeping, and you shower it off in the morning. Typically you repeat it again in a few weeks. You can also use antihistamines to help with the itching. There are some more severe cases. If they don't respond, you can use an oral agent like ivermectin, but risks of using an oral agent usually outweigh the risk of just repeating the permethrin over and over. And as far as contagiousness, I didn't look up all the details in this, but in my training, it was basically very, very close contacts. So being in the same room or examining a person, you're unlikely to get it, but sharing a bed with them, it's usually in a family if it's going to spread. Okay. So that's one gross thing that people can have.
Can't wait to hear more.
The next is lice, which we all have known of. Anyone who's ever been in elementary school has probably had a lice scare at least in their life, even if they haven't had it, known it going around the school or whatever. There's a couple different type of lice. So we'll talk briefly on each. There's head lice, body lice, and pubic lice. So they are ectoparasites. They live on the outside. They feed on human blood. They crawl. They don't jump or fly. They move from person to person with very close physical contact. In one part of an article, it said they don't usually go on fomites like combs, brushes, clothes, hats. And another part of the article, it says they do. So I would say just don't share your brushes and hats with people. The head louse, so head lice, is the most common. And we see this in all socioeconomic groups. So I've heard people say lice like dirty hair, lice like clean hair, lice like, whatever. It can happen to anybody. I don't care who you are. It can happen. But I remember that being a thing. Of course, in elementary school, somebody gets in you're dirty. No, it just happens. Very common in school-age children. About 10 to 40% of schools have had outbreaks. It affects all ethnic groups and races. It can be any hair type too, and it can be male or female. Girls are only just, what's interesting is the hair length is not why girls are more likely, which was interesting. It's because of social behavior that girls are more likely to put their heads close together, like both of them close looking at something or hugging each other or being more physical with each other than boys. And again, that's not a black and white thing. It can be any person can get it, but that's why they say it was more likely laying together on a couch, or in your bed, like, I don't know, chit-chatting or whatever. Ages 3 to 11 are the most common. All right. Head lice are typically 1 to 2 millimeters. We're going to get into like the little grossness of them.
You're making me itchy.
They are wingless, white to gray, long, flattened abdomens, 3 pairs of legs. And they live for about 30 days. They lay eggs called nits, and they glue them to the base of your hair shaft. So that's the big trouble if you get this, because you have to get all those nits out, or else even if you got all the lice out, the nits are going to hatch and they're going to have a whole new. How do they glue them? It's like something that comes out of them when they lay the egg.
Oh, like that keeps like the eggs together. Okay.
Yeah, well, like it sticks it to like the very base of your hair.
Right, but I know like other animals, when they lay eggs, there's kind of like some mucus with it that like keeps them together.
Yeah, essentially something along those lines. They typically hatch in 8 to 9 days if they're kept near body temperature. And so if they don't really live well off of people, they can, it says 10 days away from a human host, but the eggs will not. The eggs can live without a human host. The mature ones cannot. Let me get that right.
Well, what's their lifespan just in general?
30 days. Yeah. It takes about, like I said, 8 to 9 days for the nits to hatch, and then the live ones are about 30 days. And it's, like we said, it can be spread by just being very close to somebody. Now let's go on to body lice. So body lice are larger than head lice. They are 2 to 4 millimeters. And unlike head lice and pubic lice, they do not live on the human body. They actually prefer cooler temperatures. They live in the clothing. And then they crawl onto the body during the night. Females lay 10 to 15 eggs per day on the fiber of clothing at the seams typically, and same thing, they could live about 30 days, and they die 2 days away from a host without a meal.
So are they kind of like bedbugs, but different types?
Sort of. Bedbugs are technically, we'll talk about bedbugs, but they do not infest people in the same way. Okay. Body lice are typically spread in contact with clothing, bedding, or towels. And I did read somewhere, and I'm not sure if it's in this part of my notes or not, but they are more found in unhoused people just because of the congregate living situations often, using these bedding or towels. I did find that somewhere, but it's not right here in my notes. All right. Pubic lice.
The best kind?
So I remember during my OBGYN rotation that I didn't see this, but I know the patient came in early labor, and when they went to go examine the patient, they saw evidence of pubic lice, and he sent the woman home. He said, "Go shave everything bald, then come back and I will deliver your baby."
They couldn't just shave her there in the hospital?
I don't know. Not sure. I don't know. I heard the story from the attending himself. It happened while I was there. I didn't see the patient. I don't know the details, but
hopefully she wasn't too far along in her labor. Like she could.
Yeah, I think she was in early labor. That's why I was like, you can go home, shave, and come back. I guess everyone was just grossed out and scared. I mean, it is true. Like I'll walk into a room with someone with like MRSA, which is like an antibiotic resistant infection with no problem. But if someone has lice, I will be frightful. So they get the name crabs. They are an STD, and they're shaped a little bit differently. That's why they get that name crabs. And they live for approximately 2 weeks. They lay 1 or 2 eggs a day. They grasp the coarser pubic hairs. And so that's why they go to those areas. And they are less mobile than body lice are. And they can crawl up to 10 centimeters a day. They cannot survive off a human host for more than 1 day. All right, so treatment. Lice, basically you need to wash every single thing that you've been in contact with in very, very, very hot water. They say, or expose it to temperatures above 130 degrees. Things that can't be laundered can be put in a sealed plastic bag for 2 weeks to make sure that everything has died. Everything should be vacuumed, stuffed animals, everything needs to be heated. And then the treatment is similar. It's topical treatment for all of these. Permethrin, which is same thing, different strength, but the same thing we use for scabies. But you do have to, on the head especially, comb out all of those nits, which is the tricky part, especially some with longer or thicker hair. And, you can typically reapply in another week to make sure that you've gotten everything. So, there are talks about resistant strains of them. So that's a thing. There's actually an industry. I don't know if you've heard about this, like places that will treat you for your head lice.
No.
Like special hairdressers that specialize in this. Yeah. It's like a thing. I think, in some bigger cities where these outbreaks happen in a school, and it's literally a special salon for that.
Makes
All
sense.
right. Next one, bedbugs.
How many more bugs do we have to hear about?
So there's only one after this. Bedbugs basically are true bugs. So they're not, they are, I guess they call them ectoparasites, but they don't live on you. They live on your bed. They are reddish to brown, 5 to 7 millimeters in size. So that's a lot bigger than all of the other ones. And they deposit fertilized eggs in the cracks or crevices of your bedding. They occur at night. The insects are nocturnal with peak activity just before dawn. Usually only your exposed skin. So typically they're not crawling under your pajamas. And what we see typically, if I saw someone in the office, you'll see like 3 bites in a row, and they call it breakfast, lunch, and dinner. And that's how you know it's bed bugs.
Okay, interesting.
But the difference is that bed bugs, I'm not treating the person.
Mm-hmm.
The person needs to have their home treated.
Right.
But it's not, that's the difference. So when I scabies or lice, I'm treating the person.
Mm.
This, they need to exterminate and do all those things. Similarly, like the high heat is one of the big options they use. There are some like permethrin treated fabrics that I think in some areas, or it can be sprayed on certain clothing. So that is like that same chemical. But yeah, it's a bit different because it's about eradicating it from the home, not the person.
Yeah.
And there are traps. I don't know if you hear commercials for bed bug sniffing dogs. Yeah, I think because New York had a really big problem a few years ago. So I remember a lot of commercials from different places.
So what do the dogs do? Just sniff them out where they're at? Like,
I guess.
they don't do anything else. They
Yeah.
just detect them, which there's other means of detecting them.
I don't know. I'm not really sure. I just know about the commercials, but there are a couple different chemical options. There are things where they heat the whole home or whatever. But again, heat and chemicals kill them. Kill them all.
Yes, they probably don't have as many outbreaks in the summer because of heat.
Yeah, but we're talking like 130 degrees.
Mm-hmm.
So in someone's house, that's not going to happen. Same, similar heat as it is for the lice.
Mm-hmm.
All right. So last one. And this is super not common, but is kind of gross and fun. Botflies.
Oh no, these are the ones I'm afraid of.
Yeah.
I've seen
myiasis is an infestation of the skin by larvae or maggots of different fly species. And typically we're talking about this botfly, Dermatobia hominis, the human botfly, and another one called Anthrophaga cordobia. I don't know. I can't. But anyway, those are the 2 species. I know this gets really gross. So the 2 main clinical types are wound myiasis and furuncular, which furuncle is sort of like an abscess. They can also have nasopharyngeal myiasis, where you can get into your sinuses. I know, this is getting me. It's getting me too. Eyes, orbits, yeah, not good stuff. And there are a few intestinal and urogenital, but that sounds rare. Typically, the history is they've traveled to a tropical country or had a previous wound that got infected with these. And the average time from exposure to diagnosis is a month and a half. So it's a long time. Basically, you get a boil-like lesion, something that looks like an abscess somewhere, and they can be painful, tender, sense of something moving under the skin. Sometimes they'll have a fever and swollen glands. And the treatment is basically to get them out. So
No, just let them hang out in there forever.
the one approach, the occlusion suffocation approach, is to put something on top like petroleum jelly, paraffin, beeswax, heavy oil, or this one was an interesting one, bacon strips.
And the funny thing, when you were saying, like, when you were describing those, I was like, peanut butter.
I don't know. Food products, I don't know.
Because peanut
But
butter has
basically,
oil on it, and it's heavy.
yeah. So you put it, so what you're doing is you're not actually killing them with the oil. You're putting it over like the little pore that they would come in or out of.
Mm-hmm.
And then they figure we're suffocating. We need air. And that makes them come out. So usually
Where
they
did
come
they
out.
come out of if you covered the opening?
I guess there somewhere. They push their way out. 3 to 24 hours after you put the suffocating material on, they typically come out and you get rid of them. Surgical removal can happen with, putting someone under anesthesia. I guess it depends on the location and the extent of it. You have to be very careful. You can't forcibly remove them because they have like little spines and hooks on them to keep them in there. And you don't want to cut them open by accident because retained parts of them could then stay under your skin and cause a reaction there. And then there is a little bit of mention of using something systemic like ivermectin. I guess they're saying like oral or orbital when it's like inside your body like that. That can be used. And then lastly, wound myiasis. You can do like debridement with some chemicals and irrigate the larvae from the wound that way. Oh, I lied. There's one more little buggy I needed to talk about. I'm sorry.
Why?
I forgot. I had one more that I forgot, but it's a quick. I know. But this is an interesting one because you could get this going to like the beach on vacation.
Okay.
So cutaneous larva migrans. So it's the most common tropically acquired dermatosis, and it goes back more than 100 years. People have been talking about this, and it's found in some places like the Caribbean, South America, Central America, Southeast Asia, and Africa. Typically, it's from the beach. And so walking barefoot, sunbathing on the beach, something like that. Typically what it looks like is sort of similar to how we said the tracks from scabies, but these are very what we call serpentiginous. Serpentiginous meaning snake-like. So you have a picture of just often be on the side of a foot is where you'll see it if you looked up a picture. And it's just sort of like this.
Look up a picture.
There's nothing gross about this one. It just looks like a worm under your skin. Like it looks like a snaky little worm. It's small. And yeah, it happens. Typically treated with oral albendazole or ivermectin. And it's pretty very, very easily treated. And that's it. But yeah, if you go on vacation and have a weird wormy thing on your foot, get treated.
Okay.
And
thanks for that.
Stay away from foodies.
Yeah.
I've got the heebie-jeebies.
So before I move on to mine, which is related, so we're still being on the same uncomfortable topic, but listeners who follow Real Housewives are probably thinking about, during this whole conversation, about Brandi Glanville. So she is a former Real Housewife. Then she kind of got downgraded to like friend of the housewives. And recently she's been in the news because she has been saying that she has a facial parasite. And of course, people are saying she's delusional or this or that. But recently, Terry Dubrow, also of reality TV fame, husband of Heather Dubrow, of a housewife, but he's also on Botched, the plastic surgery show. He basically came out and said it's not a parasite, but it could be either some sort of microorganism that is in her blood or it's ill effects from plastic surgery that she's had. And then if you look up the pictures, she doesn't tend to have like the lesions and things like that you might see with the delusional parasitosis. It's like odd swelling and then like deflating of skin in certain areas. So it's not necessarily presenting the way you were describing delusional parasitosis, but
Right.
you know, the jury's still out on what it actually is. But when I saw the pictures, the first thing I thought was like, her fillers dissolved or like something happened underneath the skin, but not necessarily like a bug, but something going
Yeah,
on.
that would make sense. Some sort of a local reaction, your body not.
And then can't fillers drift too?
Yes.
So
there are things you can use to dissolve them. I don't do aesthetics, but I peripherally know a few things. Yeah.
It honestly, like looking at her face, it looks like something plastic surgery wise went wrong. I'm not that kind of doctor, just saying, you know, having seen what you're talking about as far as the delusional parasitosis and some of the injuries that people may inflict on themselves from it, doesn't present that way. It looks different, but I think she's getting a lot of a lot of negative press about that and people saying negative things about her. I will say she has a very messy track record, so that might be part of it too. But hopefully she gets it figured out and they help her. So if you
I'm
guys
not
are
up on all the
listening,
housewives anymore. I
yeah,
only know the New Jersey ones because, you know,
wow,
we
the
live
New
in
Jersey
Jersey.
ones are mostly new now. They got rid of a lot of people.
Yeah, I haven't watched. I watched like back when it was like huge.
Yeah. So my drink today is called the Fuzzy Navel, and that is, we'll tell you guys how to make it. Super easy. 3 ounces of peach schnapps, 3 ounces of orange juice. The recipe says freshly squeezed. I use just the bottle stuff because I didn't have time for that. Pour that over ice, stir it briefly to combine it, and then garnish with an orange slice, and there you go.
Nice.
And so the movie that I'm going to talk about today is a documentary, and it is called Skin Deep, The Search for Morgellons, or Morgellons. Skin Deep, The Battle Over Morgellons. It's on Amazon Prime, came out in October 2019. There is a website for the actual movie if you wanted to learn more about it. It's called morgellonsmovie.com. And all the other links and stuff that I'm talking about will be in our show notes. So the documentary starts out by talking about how people are presenting to dermatologists mainly, with these really bizarre symptoms. And a lot of dermatologists are referring their patients immediately to psychiatrists or, basically putting them on antipsychotics to deal with it without fully looking into what some of these patients are saying. And it gets really convoluted, but I have got the main parts of the documentary that I'm going to talk about because the kind of cast of characters, I use all real people, but I think it gives you a really good idea of kind of the spectrum of people who it's affecting and where the research is going moving forward. So the documentary starts off talking about like all these news clips, like, people presenting with this bizarre skin disease where fibers or hairs are coming out of their skin. And so that's all they talk about. And then they say, just really offhand, like super, like no one's going to listen to this. They're like, oh yeah, famous singer Joni Mitchell has it. And then they never mention it again. And then I Google it and there's very little details about it, but she does say that she has it. So that's something. So then they go into it. And the first person that you meet in this documentary is probably my least favorite person. Now, this is a personal reaction to this guy, but I have a feeling for those of you who watched the documentary or who will watch it, you'll kind of get the same feeling about him towards the end of it. But he's a dermatologist. He initially comes across as very personable, very funny. And then he makes this comment that just like really made me cringe. He said, oh, well, when you follow me to my office, you're going to think that I'm so great with patients and that I'm so spontaneous and I'm just so great. He's like, but I do the same thing with every person. It's all an act. And like it really bothered me. I don't know about you, but like of course I have the same way of saying things. Like I kind of have, the same way of explaining stuff because most people understand it. But he's literally from the door, like talking about how he takes hand sanitizer and like the way he introduces himself and the way that he talks to people. It's the same exact time with everything.
Is he like an automaton? He's like.
And so right off the bat, that really gave me an easy feeling about him because he's clearly not taking a personalized approach to each patient.
Right.
He's kind of going in, he has his preconceived notion. He's just doing his thing, getting them in and out. Now, of course, in the documentary, they're only showing him with these patients who are presenting with Morgellons. So maybe this is how he approaches these people who he believes have delusional parasitosis. So maybe he's already kind of got his own script about how to manage it. And that's
right.
Like they never show him with somebody else. So you don't really know if he's better with someone else, but he's kind of cringe from the start. And so, as Tara just said, delusions of parasitosis are this belief that someone has bugs or parasites under their skin. And when they first start talking about it, he's Dr. Feldman. He's a dermatologist, and then he just pats himself on the back. He's like, well, I did 6 months of psychiatry too. So, of course, then he knows all about mental health.
Of course.
6 months of psychiatry. Whatever,
got it.
Sure. I feel that way when people are like, oh yeah, I did like Psych 101. Well, great, wonderful, but that doesn't make you a psychologist. They go on, the documentary itself, I believe, I don't think he says this exactly, is that when they see patients who are presenting with this complaint that they have something under their skin or something coming out of their skin that they don't find upon examination, They're saying that these people either have delusions of parasitosis or hypochondriasis, which we now call illness anxiety disorder. So
I didn't know we changed the name.
Yes, we did change the name. We made it because, everybody's been called a hypochondriac. It kind of gone this negative connotation where illness anxiety disorder, it's part of somatic disorders. And it's when someone is very, very concerned about getting sick. They may not have symptoms or they'll have symptoms and then they're jumping to, oh, I have a cough, so I have to have tuberculosis. So like they have actual symptoms, but then they're assigning it to something more severe.
Right.
And so that's kind of what illness anxiety disorder is. But like many other somatoform disorders, which I'll talk about later, there is an underlying mental health thing going on. A lot of these people might have trauma or severe anxiety or depression, and then it's kind of manifesting in these physical symptoms. So that's just a quick overview of illness anxiety disorder. So then we start to meet through the documentary, a couple of patients who say that they have Morgellons. And so I'll just go over what most of the common reported symptoms are. Low-grade flu symptoms like fever, achiness, fatigue. Some people report swelling in their hands or feet or other areas, headaches, anxiety, fatigue, brain fog, so that's difficulty concentrating, not really being able to focus on what's going on around you. And then there's the painful sores or lesions that people are presenting with. That's usually what they're presenting to a dermatologist for because it's something you can visually see. One person in the film says that they describe it as the feeling of pop rocks under their skin. So if you ever ate pop rocks as a kid, like kind of imagine how that might feel under your skin. That sounds really uncomfortable.
Snap, crackle, pop.
Yeah. And then the most unusual, also just sensory sensitivity on or under the skin. So one woman is describing it, how it constantly feels like, how when you have a piece of hair on your skin and you kind of like brush it off.
Right.
She's constantly having that feeling, but then looks down and like there's nothing there.
Okay.
Then there can also be itching. But the one very, very unusual symptom that seems to correlate only with people who are presenting with Morgellons is colored fibers or filaments embedded deeply under the skin surface. And so that's kind of what's setting it apart from other people who may say they have delusional parasitosis or things like that. Upon examination, we are finding these fibers under the skin. And when the documentary starts, we don't really know what they are. We don't know where they're coming from, if they're from clothing, like Dr. Feldman, he's like, oh, that's just from what you wore today. But they're, embedded like deep in the skin. They're not on the surface. It's not like if you just scrape off the first level, you could pull the fibers out. They're pretty deep on in there. And they can be clear, black, red, blue. I think those are the main colors that they talk about. But definitely something unusual is going on with those things. So then Dr. Feldman again is saying how he doesn't believe in Morgellons and he thinks that it's just flat out delusions or psychosis and these patients need to be treated with mental health medications. Then we meet someone named Cindy Casey Holman. Wow, get that right. She's a former ICU nurse and she started to have those symptoms of Morgellons first, those other more, I want to call them viral type symptoms, but like, the flu-like symptoms and things like that. She started with having that and then it progressed into these unusual marks on her skin and then the itching. And then upon further examination was finding those fibers embedded under her skin. And there's a very, very sweet story about how in the midst of her illness and trying to figure out what's going on, she meets this man and they get married and he just is the biggest advocate for her and everyone else in the Morgellons world. He's going to doctors. He's asking for how does he get CDC research. He knows all the terms. So he says to one doctor, oh, I'm not going to matchbox you. We're not going to bring in the materials because we know you're just going to like label her right away and throw her out.
Right.
And then one doctor who they talk to, I believe I have his name in here. I believe it's Dr. Timothy Berger. They talk with him and they record him without his knowledge, which ethics on that, not great. I don't know what state they live in, but certain states you do have to have permission of the person that you're recording. But basically in an office visit, this doctor that they're talking to says that, okay, if it's not delusions of parasitosis, whatever she has, the science isn't there yet. So we can't treat it. We can't diagnose it because we're not there yet. Which I find really interesting because if we're looking back in medicine, that's happened before. There's been illnesses that we didn't know what to call or we didn't know how to treat until the research caught up with it. So it's possible that that's what's going on. But I liked that he took that approach of, well, it could be this or this, where a lot of the doctors are just shutting it down as the patient's being crazy from the start. There's another patient who comes in. She's only there very briefly, but she's wonderful because right off the bat, she's like, well, I'm doing the whole psych protocol for it. I'm taking ORAP, which is an antipsychotic. She's done everything that the psychiatrist that they referred her to do, and she's still having these feelings. So she goes back to Dr. Feldman and explains to him that, like, look, maybe there is some mental health stuff going on, but I still have this. So I still want an answer for this. He essentially kind of blows her off.
Right. But that's like a really great patient that they're doing everything. And it seems like they have insight into this could be possibly this. So that to me says it's, if they have insight, that it probably isn't a delusion.
And this is skipping ahead, but this is why I don't like Dr. Feldman. He goes at the end of the documentary, he goes to a conference just for people who have Morgellons and the researchers looking into it. And he gives a talk on how to be a better patient. And he tells all of these people that they need to be nice to their doctors, they need to listen to them and do what they say, and they need to go for several visits, and then maybe a doctor will take them seriously.
Wow.
And of course, there's an eruption in the room, and people are yelling at him, and
he's
nobody cursed him
everybody,
out, which I was very surprised because I would have if I was there.
Yeah, I think people start throwing tomatoes at him. Like
there were definitely people who had to escort themselves out because they were getting like physically riled up.
Yeah.
So yeah, he's
not nice.
He doesn't seem like, and that's another thing he says during his talk is there are no bad doctors. And he makes the joke.
None.
Yeah, he
None.
makes the joke of, what do they call the person who graduated last in their medical school? Doctor. So
right.
He's like, they're still a doc, basically saying they know better than you, so you have to like bow down to them.
Oh, geez.
So not the most comforting, great approach. But I mentioned before, Cindy Holman, she is part of all of this advocacy. She organizes this conference, and she's a nurse. She's been an ICU nurse for a very long time. And so she has that medical background. And so she understands why, some people may be diagnosed with this delusions of parasitosis, because when you see those shots of the conference, there are definitely people there with severe mental health issues, without a question. They do like very quick interviews with them, and there's this one man who seems super sweet, but he's holding up this picture of what he says is a worm, and he says that there's 60 billion of them in his groin. And he's he's very flat affect. He definitely seems like there's something else going on. And luckily, it seems like everyone at the conference is very supportive of him. So at least it's a positive environment for him. But I could definitely see how if that man walked into a doctor's office right away, they would be like, no, he's crazy. Just because of the way he's presenting. It doesn't mean he doesn't have something. And I think that's something that is only covered slightly in the documentary is you could have both. You can have severe mental illness and still have a medical illness.
So it's interesting, though, because this seems to have a community, this Morgellons, or it seems to have like people, I'm sure there's internet groups and stuff. I don't think there's internet groups for delusional parasitosis because you're in denial of it. But I bet there's like a mixed picture where some people with delusional parasitosis get into the Morgellons world.
You're skipping ahead because there's a part of the documentary about that, about how Dr. Timothy Berger, he says that it is an internet-based disorder. And that he never heard about it until these groups organized themselves. And he likens it to, buckle up, Agent Orange and nuclear bullet war exposure.
Okay, well, I have patients who have Parkinson's from Agent Orange, so that's for real.
Yeah, so the examples he's using are actual real things that people...
And what did you say, nuclear war?
In Bosnia Fallout? And other places, God. Where they were using like nuclear like weapons. The people who use the weapons or were near exposure sites. He's likening Morgellons to that, which I think those are actual disorders. So
So
as we're learning, maybe not every doctor is a good doctor.
Right.
I will say though, taking those two, with a grain of salt, there are several doctors and professionals in this documentary who, even if they do think it's delusional parasitosis, are much, much better with their patients and helping them to seek the appropriate treatment, whether it's psychological treatment or other medical research. But there's a wealth of other really good doctors in there, so I don't want like a couple of apples to ruin the bunch for people.
Right.
There's also this gentleman in the documentary who I find fascinating. And I did a deep dive on this. I'm not going to talk about it because it could be a whole separate episode. But his name is Harry Quinn Schoen, and he's a medical historian. And his dissertation was on Morgellons, but he also has written a book called Contested Illnesses in Context. And so it's talking about how people have these illnesses that the larger public may not believe in, like fibromyalgia is another big one, Morgellons, things like that, where he talks about the experience of the people who have those disorders or who say they have those disorders and how difficult it is because they have to prove themselves to doctors, to their families. They question themselves a lot. And so how that sometimes can make the symptoms worse because as we know of the mind-body connection, if you're feeling overwhelmed or anxious or depressed, that's going to make any physical symptom that you have 100 times worse. So kind of saying how they're feeding on each other.
Right. I mean, there's been a lot of research and understanding just pain and psychiatric and depression and feedback loops, and any symptom can be absolutely exacerbated and it can become a vicious cycle. So it's interesting. I like this guy, the historian guy. I want to look at
he's
his
great
stuff.
because he goes to these conferences. He talks to everyone from the guy who's got the 60 billion in his groin to the researchers so he's getting like a really balanced exposure to the information, and is just trying to remain like the neutral party, like saying, let's treat these patients as they deserve to be treated, whether it's one thing or another.
Right.
So I really
because mental illness is an illness still.
Exactly. And he talks a lot. Well, he doesn't talk a lot. Apparently in his book, he talks a lot about just the difference in when patients have a contested illness, how they are made to feel responsible for their disorder, or to feel shame about it, to feel like they have agency over it. They've caused this to happen to themselves, where we wouldn't treat a cancer patient that way. We wouldn't treat someone else that way. And I think a lot of it goes to what he says. If we don't have the research, there's a lot of doctors out there who aren't going to do the research themselves, whether they just don't have the time, or they don't, have the mental energy, or they just truly don't believe that it's there. And so they don't talk about this in the documentary, but it really made me think about like confirmation bias. If we're looking for something, we're going to find it all the time. So maybe we also have exclusionary bias, where we feel like it's something that's not real. We're not going to see it. We're going to miss it. And there's even a part that they talk about how the CDC did research. They did their own task force for Morgellons with Kaiser Permanente, $600,000. And 4 years later, they said Morgellons does not exist. But then some of the researchers who are really on the forefront of looking into this said that their research was flawed because their operational definition of what Morgellons is was wrong. So basically, they were looking for patients who said that they had fibers under the skin, not people who actually had it. So if someone was self-reporting it, they got into the study. But if someone was like, well, I'm not sure what it is, they did not get into the study. And then they didn't.
Sorry, I'm eating a gummy worm.
I love it. She's going to shove that gummy worm in her mouth. But they didn't look to correlate if those people who were saying they had the fibers under their skin actually had it. And so that does seem like a little bit of flawed research to me. They were also already going from a research base. They weren't recruiting new patients for this research. So that also seems like, well, I'm sure there's a lot of people who maybe never made it to the research database.
So are we biopsying and actually finding these under a microscope?
So what is that?
Okay.
So, we already talked about the matchbox evidence, so I'm not going to go into that. You already talked about folie à deux, folie à famille. We had actually a lot of overlap on what we were talking about, even though we weren't sure that we would. So I'm not going to go into a ton of stuff. Oh, there's one more guy who's in this who I found really interesting. His name is Edward Hugh, or Who, I'm not sure, Ichio. And he is a former federal attorney, and his brother, Brian, is an MD. And Edward claims that he has Morgellons, but all of the symptoms that he talks about, no one else in the documentary talked about. So he says that he has extreme nerve pain, word-finding difficulty, tremors, gross motor problems, gastrointestinal problems, electrical interference. So he says that if he's using a cell phone or a computer or the microwave or something, it'll just short out. And he says it's the electrical impulses on the fibers in his skin, kind of like static electricity.
Okay.
Is causing that. So I find him really, he also at one point washes his body with a scraping stone to get rid of things. Yes, there's other really painful to watch treatments that people use. One guy uses DDT on his face to get rid of lesions. Another guy burns the hairs off his skin with a lighter. So these patients are desperate. That's the way that I took it, is like they're going to these extremes just to feel better. And for a lot of them, it's only temporary. So I find Edward really interesting because he's a clearly highly intelligent man who's having all these issues. He was debilitated enough by these issues to have to retire from his job. And he's very young. I think he's maybe 30 in this documentary. So his whole life just gone to shit over this. And his brother right away tells him, you need to see a psychiatrist. So they have a huge family rift. And I think that's really important because that's what these patients are going through. Their doctors don't believe them. Their family doesn't believe them. They start to think that they're crazy. Then they isolate because they don't know what it is. They don't want to be judged. So it can really affect someone's mental health in many different ways. But there's certain parts of watching Edward in this documentary where he seems truly mentally ill. Like some of the things that he says and the ways that he acts give a very much schizophrenia type feel. So I could see why his brother would jump to that. Now, I don't know if that's just, his personality, he's a little quirky and, out there, or if he's just so overwhelmed by whatever's happening to him that he's not explaining himself clearly or seems a little off. But he ends up getting treated with antibiotics, which I'll get to in a little bit, and all of the symptoms clear up. So if he's got schizophrenia, last I checked, antibiotics aren't going to get rid of those symptoms.
Right. Even, you're not going to, that's not going to clear up. I mean, you may believe a delusion is improved, but the rest of the symptoms would still.
Exactly.
Right.
And so just to answer your question from before, there are researchers out there who are looking at things. They're taking biopsies, they're doing samples. And one of the major resources of this research is a woman named Marianne Middleveen. And she is actually a doctor of veterinary science. And when she first heard about Morgellons, she recalled that there's a certain disorder in cows called bovine digital dermatitis, where cows in their hooves, they get unusual hairs growing out of them. And it is caused by a spirochete.
Huh.
So where else do we see spirochetes in humans?
Like tick bites?
In Lyme disease. So they start to make a correlation between Lyme disease and Morgellons.
And the antibiotic would cure Lyme.
Both of those. Yes.
Huh.
So I'm not going to go in the deep dive because I just want to be mindful of it. But essentially at the end of the documentary, the research is showing that people that they are treating with antibiotics, a large percent of them are getting much better. The other thing is a spirochetal infection can cause psychiatric symptoms. So this might be kind of taking both of those things and putting them together and say, yes, they do have a medical disorder, but when they present to you, they may present with these unusual behaviors, symptoms, way of speaking, way of acting.
Wow.
The sad part of all this is there's a nurse. Her name is Ginger Savley. She's written a book on all of this. She's phenomenal. Also, she's a great advocate for people in the community. She says that the mental impact is huge. Like I was saying before, the isolation, feeling abandoned, people not believing you, the distress, being desperate. She said that I don't know if this is a true statistic, but she said that she has lost a lot of patients to suicide and that they are 800 times more likely to commit suicide than other patients. Which I would guess would probably happen for anyone who has an uncontested illness. It's the same kind of feelings, same desperation, the same loneliness, which we know hopelessness and helplessness are highly correlated with suicide attempts and suicidal ideation.
Yeah, just feeling out of control. There's nothing I can do, and suffering on a day-to-day basis could drive anyone.
Exactly.
Yeah.
So just to wrap up, you might be like, where'd the name Morgellons come from?
Right.
Well, there was a woman named Mary Lado in 2002. Her son had symptoms of this, and she was accused of Munchausen by proxy. And in her attempt to defend herself about this, she started doing some research, and she went all the way back to 1690 in a paper written by Sir Thomas Browne that said that there were children who had unusual hairs growing out of their skin and were bothered by them. And so it happened in the Morgellons, I believe, area of France. And so that's where she came up with the name Morgellons.
It's all about France.
It is. I mean, I love France. I'm trying to make sure. I think I hit everything on that. The last important part is there are other disorders that we know in the past were contested or not believed that are real. So for a very, very long time, syphilis was considered psychosomatic until we did research into figuring out where that came from. I believe that also has spirochetes involved, doesn't it? I know. Sorry, testing you on that one.
Tryponium palladium, whatever that is.
Okay, can't help
that's syphilis.
Yeah. And then lots of other things. In the past, we've seen that things like bipolar, anxiety, and depression can be comorbid with physical health symptoms. So again, trying to figure out the difference between a somatoform disorder, like I said before, a disorder that is caused by extreme emotional stress that is now evidencing itself in physical symptoms. Psychosomatic disorder, that's what most people think of a somatoform disorder, where they're presenting with the mental health symptoms first. I'm sorry. Psychosomatic is when they're presenting with the physical health symptoms, but we know that they're connected to mental health symptoms. But somatopsychic disorder is the other, where you have a physical issue, it's real, and because the treatment or the difficulty with it or just the managing your day-to-day with that physical disorder can cause mental health problems. So it's really, which comes first, chicken or the egg.
Chicken
A
or
lot
the
of
egg.
people don't use that term, somatopsychic, but it is an actual term.
Interesting. And where I know this is an offshoot of something we'll do eventually too, but conversion disorder, where does that fall on those terms?
So conversion disorder is when someone is presenting with symptoms that we can't at all find a medical reason for. So like psychosomatic disorders, someone could say, I have fatigue. And then you see that they're fatigued and they're tired all day. So you're seeing some manifestation of it, but you don't have a medical cause for it. Where
right, because conversion is always neurologic. Like my leg doesn't move, but you can't find a physical reason for it. It's so complicated, these interplays. And I'm sure we don't really know. We're just classifying based on the information we have.
Exactly. And I think like that, like you just said about conversion disorder, a lot of times we're going to see that in larger things like limbs not working, seizures that have no medical basis, things like that are more, I don't want to say global, but does that make sense? Right. Where it's a larger issue than just itching under the skin. The last thing I was kind of curious about, they don't talk at all, other than the antipsychotic medications, about how someone may be treating in mental health when someone is presenting with Morgellons or a contested disorder. And the only experience I have is in working with AMPS patients. Do you know what AMPS is?
No.
So it's pediatric amplified pain syndrome. It's basically people call it like baby fibromyalgia because it happens in kids. Mm-hmm. And some of that treatment is very difficult because basically you don't address the pain at all. You talk about how to get someone back to functioning, what is getting in their way, how to help their mental health feel better, but you do not address the pain. And so I would imagine if someone is presenting with these delusions, like you said before, like not kind of feeding into the delusion, not going with it, just trying to treat the symptoms, I think that might be really difficult too, to get buy-in from a patient. If they say, I have pain and I want to talk about my pain, and then you can't talk about their pain.
Right.
So we have a lot of work to do, both medically and psychiatrically in treating some of these contested illnesses. But I really liked that topic. I thought it was a really cool topic.
Yeah, I mean, I'm definitely learning from the podcast how much our fields are intertwined in ways that I didn't even realize they were, if that makes sense. It's interesting. We're learning from each other.
We are. I mean, I think it's funny. I've had patients say to me, like, why are you asking about my thyroid? Or why are you asking about this? I was like, because they're all related. And a lot of times, unfortunately, still to this day, a lot of medical doctors will tell someone to go to a psychologist or a psychiatrist. So I need to know all those medical things that could be going on that could look psychological or look psychiatric, and then help those patients suss it out. Because if they're coming to me and it's their thyroid, I can't fix their thyroid. So they're still going to be anxious, or they're still going to be depressed. And then they're going to think that nobody can help them, where maybe it's just something that the medical doctor missed.
Right. All right. Wow. Interesting topics. Yeah. So at least your end wasn't as gross as mine. So
no,
that's good.
Well, I thank God. I couldn't do a gross one. I'm sure there's some gross ones in psychology that I'm over. Like, I don't think it's gross anymore, but
goodness.
Wasn't doing bugs. No, thank you.
All right. So that was to bugs. I'm going to have to eat the rest of my gummy worms. They do soak up some of the drinks, so then they get chewy.
Like sangria.
Have you ever had, we used to do in college, like gummy bears or gummy worms soaked in vodka? Mm-hmm. Yeah, essentially it's that, except for it's a drink, so it's not as concentrated, but. All right. So I think, we need to just plug our socials. So as of this moment in time, TikTok is no longer around. Mm-hmm. I don't know if when we air this, it will be back. But if so, still look for us there, Medical Media Mixer. Our main formats right now are Instagram and YouTube, as well as Pinterest. And we are available on all major podcasting platforms. So tell your family and friends if they aren't sure. Everybody's got either Amazon Music, Spotify, iHeart, Apple. If they aren't, help them download it on their phone so they can listen.
Yes, I've had to do that. And you know what? It takes us a second and it makes them very happy.
Exactly. So, tell your friends and family. Definitely shoot us emails.
Yes, medicalmediamixer@gmail.com.
There you go. Hopefully we'll get some emails with some feedback, and we'll be hoping to get right back to you and maybe include things in future episodes. And I think that's it. All right. So thank you for listening to Medical Media Mixer.
The perfect cocktail. Cheers.
Cheers.